Hello and welcome. This is Dr. Farhat with you. I'm a student of Diploma MSc Diabetes at University of South Wales. In this video, I would like to shed some light on diabetes and its associated risk factor for cardiovascular disease. So let's begin. As you all know, that diabetes is associated with chronic complications, and the complications of diabetes can be divided into microvascular complications and macrovascular complications. Microvascular complications are the diseases caused by damage to the small blood vessels caused by diabetes. It can lead to diabetic retinopathy, which is eye disease, nephropathy, kidney disease, and neuropathy, which is the disease of the nerves of the lower limbs. Whereas the macrovascular complications of diabetes is the diseases caused by damage to the large blood vessels of the body due to diabetes. It includes stroke, heart disease, and peripheral vascular disease. Compared to the normal population, diabetic patients have a 2 to 4-fold increase in cardiovascular mortality and stroke, which is death from cardiovascular diseases and stroke. As we just saw that diabetes is associated with macrovascular complications, which are coronary heart disease, commonly known as heart attack, cerebrovascular disease, known as stroke, and peripheral arterial disease, which is cold and dead limb, which may require amputation. Now, the macrovascular complications of diabetes are caused by a process known as atherogenosis or atherosclerosis. It is a very complicated process as a number of pathophysiological processes are going on at the same time. But let me simplify this for you. Here you can see a normal blood vessel with a normal blood flow. And this is an artery in a diabetic patient where, due to high blood pressure, high blood glucose and high cholesterol levels, there is damage to the blood vessels and deposition of plaques in the arteries. These plaques lead to obstruction of blood flow, leading to decreased blood flow to the brain, heart, and lower limbs, which eventually leads to heart attack, stroke, or cold limb. Now that you know that you have high risk for cardiovascular disease, do you need to test for cardiac disease on a regular basis? The answer is no. Cardiac investigations are needed only in the presence of symptoms. Symptoms such as shortness of breath, chest pain or discomfort, leg cramping, abnormal ECG, exercise intolerance. If you have any of these symptoms, your physician may suggest you to have cardiac investigations such as echocardiography, angiography, carotid Doppler, ECG stress test. So that now that you know you don't require a routine cardiac assessment, what you require is regular assessment of cardiovascular risk factors. Let's take a look at the risk factors for heart disease. These can be divided into non-modifiable and modifiable risk factors. The non-modifiable risk factors include age, gender, genetic factors, race, and ethnicity. These are factors that you have no control about. Whereas the modifiable risk factors are those that you can intervene and take control of in order to decrease your risk for cardiovascular disease. These include high blood pressure, smoking, diabetes, physical inactivity, obesity, and high blood cholesterol. Let's take a look at them one by one. First of all, diabetes. How do you control your diabetes? You need to decide a target HbA1c with the help of your healthcare professional and aim to achieve that HbA1c. HbA1c reflects your control of blood sugar over the last 3 months. According to most organizations, an optimal HbA1c is less than 7%. A more tighter control, such as HbA1c less than 6.5%, can be aimed in selected patients, such as those who have a shorter duration of diabetes or a long life expectancy. A more relaxed control, such as HbA1c less than 8%, is preferred for patients who have long duration of diabetes, multiple comorbidities, severe hypoglycemia, limited life expectancy. Let's take a look at what does the evidence say regarding target HbA1c. Numerous trials were conducted to study the effects of intensive glycemic control over the diabetic complications. These trials showed that tight glycemic control with A1C less than 6.5% was associated with decreased microvascular complications, but there was no significant benefit noted for cardiovascular complications. In fact, a tight glycemic control was associated with various side effects such as severe hypoglycemia, weight gain, polypharmacy, and in fact increased mortality in certain cases. So now we know that mere intensive glycemic control, the sugar control, is not sufficient to decrease your cardiovascular risk. What is required is a multifactorial risk intervention that addresses all risk factors for cardiovascular disease. Your physician may suggest you to have self-monitoring of blood glucose in order to achieve your target HbA1c levels. These are the target blood sugar levels given by the American Diabetes Association, fasting blood sugar level of less than 100 and a 2-hour post-meal glucose levels of less than 140. Self-monitoring of blood glucose is more essential for patients who may be using insulin or in order to adjust their insulin dose and in order to detect hypoglycemia. Lifestyle changes for diabetes control. For any of the cardiovascular risk factors, lifestyle intervention is the initial management of all the cardiovascular risk factors. Let's start with dietary recommendations given by American Diabetes Association. There is no one-size-fits-all eating pattern. The eating pattern has to vary according to taste, traditions, and preferences. What is essentially required is to eat healthy food, but limit calories consumption to less than 2,000 calories per day. You may also increase your intake of high fiber, low glycemic index carbohydrates. What we mean by glycemic index is that each carbohydrate has its own glycemic index. The carbohydrates that rapidly raise your blood sugar levels are known as high glycemic index foods, such as potatoes, white rice, white bread, whereas low glycemic index carbohydrates raise your blood sugar levels gradually, and these include fruits, vegetables, whole grains, and pulses. And you need to substitute your full-fat dairy products with low-fat dairy products and oily fish. You must decrease your intake of foods containing saturated and trans-fat fatty acids, such as fast foods and processed foods. And the most essential is stop smoking, because smoking is a very important risk factor for cardiovascular disease. You may attend smoking cessation programs that are available in various healthcare facilities, and the health professionals there can help you to quit smoking using counseling and even medical therapy. When you start your diet and exercise, what a type 2 diabetic patient needs to aim for, if he has a BMI more than 25, his initial weight loss target should be 5 to 10% of his initial body weight. Now, exercise recommendations for diabetes control given by the American Diabetes Association. Exercise improves your A1C levels, lipids, blood pressure, and insulin action. When the insulin in your body starts working more, it will eventually lead to decreased requirement of medications and improved blood sugar control. The recommendations include more than 150 minutes per week of moderate intensity aerobic activity, activities such as walking, running, and swimming. You can go for a 30-minute walks at least 5 days a week. Then you have resistance or weight training for more than 2 times per week, if the weight training is not contraindicated for you. Weight training is contraindicated in conditions such as eye disease, retinopathy, and peripheral neuropathy. reduce your sedentary time. If you're doing a sedentary office job or a desk job, then you need to break up your sedentary time, which is, if it is more than 90 minutes, break it up by bouts of physical activity, such as a short walk or taking a flight of stairs. Let's take a small discussion on medical therapy for diabetes. A variety of anti-diabetic drugs are available with different potency to reduce blood sugar. You need to discuss with your doctor what is the right choice of medicine for you, after considering coexisting medical conditions, contraindications, the cost effectiveness for you, as well as the drug efficiency. Three classes of anti-diabetic drugs have particularly shown to be of cardiovascular benefit, which includes metformin. Metformin is usually prescribed as the initial anti-diabetic drug for most type 2 diabetic patients. It confers cardio protection. Then you have the SGLT2 inhibitors, the gliflozin drugs, which are beneficial in both atherosclerotic cardiovascular disease and heart failure. And injectable GLP-1 receptor agonists, which is the glutide drugs. Specifically, liraglutide was seen in LEADER trial to provide cardio protection. As I told you, that metformin is usually the first-line agent. With regards to the second-line agent, SGLT2 inhibitors, particularly empagliflozin and canagliflozin, are recommended to be prescribed as second-line agents for patients with high cardiovascular risk. Whereas patients who have a high BMI and high risk for cardiovascular disease and uncontrolled blood sugar levels, injectable GLP-1 receptor agonists may be prescribed as a second-line agent. You may discuss this with your doctor. Nowadays, patient engagement is highly encouraged in the management of chronic diseases. You should obtain information from your doctor regarding your options and involved in shared decision making. Insulin for type 2 diabetes. As you all know, that insulin is the main line of management for type 1 diabetes, but insulin is also recommended in type 2 diabetes for patients who are not controlled with oral medicines, or for a short duration for patients having severely uncontrolled blood sugar levels at the time of diagnosis or any time later during the course of their disease. As a matter of fact, if you have type 2 diabetes, you should know that even if you are initially controlled with oral medicines, you may eventually require insulin due to failing pancreas with the long diabetes duration. So if you are prescribed insulin, then it is not a sign of failure. Physicians and patients must not delay insulin if a patient is not controlled on oral medications. With regards to prescribing insulin at the time of diagnosis, if the A1C is more than 9%, it is because the UK prospective diabetes study showed that early and intensive glycemic control in type 2 diabetes reduced cardiovascular complications in the long term. However, if you are started on insulin, you must get full education of how to use insulin, the symptoms and management of hypoglycemia, as insulin use is very commonly associated with hypoglycemia. Let's move on to the next cardiovascular risk factor, which is hypertension. Hypertension is high blood sugar, high blood pressure, which is BP more than 140 systolic and 90 diastolic. Hypertension is a major risk factor for both atherosclerotic cardiovascular disease and microvascular complications, and blood pressure medicines have shown to decrease these complications. What should be the target blood pressure for diabetic patients? According to most organizations, the target blood pressure for diabetic patients should be less than 140 systolic and less than 80 diastolic blood pressure. Lower targets, such as blood pressures less than 130/80, can be aimed for selected patients who have high risk of heart disease if there is no undue treatment burden due to multiple drugs and their side effects. More intensive blood pressure control, less than 120/80, was studied in various trials, and it showed that such intensive blood pressure control confers no additional cardiac protection. In fact, it may cause adverse effects such as hypotension and electrolyte abnormalities. So individualized blood pressure targets, considering age, other coexisting medical conditions, and vascular diseases, should be considered while deciding for the blood pressure target. Management of blood pressure with lifestyle interventions. As I told you, weight loss through diet and exercise is the initial management step for all cardiovascular risk factors. Then you have the DASH diet, dietary approaches to stop hypertension, which entails you have to eat more fruits and vegetables and low-fat dairy products and eat less of salt. Salt restriction is prime for control of blood pressure, and you need to limit your salt intake to less than 2 grams per day. And you need to limit your alcoholic beverages. And you have to increase your activity levels as exercise improves peripheral blood circulation and decreases blood pressure. The blood pressure medications usually started if there is little response to lifestyle changes, or at diagnosis the blood pressure is more than 140/80. Blood pressure medicine, when it is initiated, it should be continued alongside lifestyle changes. You must discuss with your doctor the right choice of blood pressure medicine for you with respect to the benefits and risks, side effects, coexisting medical conditions, and the cost of those medicines. You have some commonly available options, which is ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, and diuretics. For a diabetic patient with atherosclerotic cardiovascular disease or albumin in urine, which is kidney disease, ACE inhibitors or angiotensin receptor blockers are the first options, as they provide both renal and cardiovascular benefits. Cholesterol abnormalities. High blood cholesterol refers to increased LDL cholesterol, VLDL cholesterol, or high triglycerides. Or cholesterol abnormality may even be refers to low HDL cholesterol, which is an HDL of less than 40 for men and less than 50 for women. HDL cholesterol are the good fats that protect the heart. So a new term has been recently coined, which is known as non-HDL cholesterol. Basically, what it entails is the good fats minus the bad fats. It gives you a measure of all the bad fats that can cause clogging of the arteries. So a high non-HDL cholesterol is a risk factor for cardiovascular disease. Diabetic patients usually have coexisting lipid abnormalities. The classic pattern is a high triglyceride and a low HDL cholesterol level, which entails high risk for cardiovascular disease. So lipid profile should be obtained at the diagnosis of diabetes and then annually or every 2 years according to the age of the patient. The cholesterol targets. These are the standard cholesterol targets. There is not much discrepancy regarding the target cholesterol levels. So you should aim to achieve these targets with lifestyle interventions and with medical therapy. The lifestyle changes for cholesterol abnormalities include, once again, weight loss, a decreased consumption of saturated fat, trans fats, and cholesterol, which is found in fast food, fried foods, confectionery items such as pastries, cakes, and processed foods. You should increase your intake of dietary omega-3 fatty acids found in tuna, fish oils, fatty fish. Increase your intake of viscous fiber such as oats, legumes, citrus, and plant sterols, which are found in vegetable oils, nuts, and seeds. And lastly, increase your activity levels. The medical therapy for high cholesterol, to target the high LDL cholesterol and non-HDL cholesterol, the best drug is found to be statin. The statins have shown to be cardioprotective. If cholesterol levels are not controlled with high-dose statin therapy, which is about 40 to 80 milligrams, a second medicine may be added, such as ezetimibe or PCSK9 inhibitors. For high triglycerides, fibrates, omega-3 fatty acids, and niacin can be used. Your doctor may help you to decide on a management plan for cholesterol by choosing the right medicine suitable for you. But if your doctor has prescribed for you a combination of medicine, statin plus fibrate, you must watch out for symptoms of muscle pains and weakness, as the combination statin plus fibrate carries a risk of muscle inflammation. Moving on to aspirin therapy for heart disease. It is a common belief that if you have diabetes, you need to use aspirin on a daily basis. But having diabetes alone is not an indication for aspirin. It can in fact increase your risk of bleeding from the stomach. So what is the indication for aspirin? Diabetic patients with known atherosclerotic cardiovascular disease, such as a previous heart attack or stroke, are prescribed aspirin. For diabetic patients without atherosclerotic cardiovascular disease, but having high risk for such a disease and age more than 50 years, not at increased risk of bleeding, may be considered for aspirin therapy. However, there is conflicting evidence for use of aspirin in primary prevention, that is, in patients without any history of atherosclerotic cardiovascular disease. So now to summarize, in order to decrease your risk for cardiovascular disease, have a healthy lifestyle with balanced diet, stop smoking and increase physical activity, be compliant with your medicines and your doctor's appointments, set targets for your weight, blood pressure, glucose, lipids, and attain them with the help of your doctor using both lifestyle and medications. Attend structured education programs available in your area to get education on self-management of diabetes. Example of few such courses found in United Kingdom is Desmond, Daphne, and Expert course. Thank you and have a nice day. Hope this talk has been beneficial for you and may help you to decrease your cardiovascular risk in the future. Thank you.